Deep anterior lamellar keratoplasty, or DALK, is currently the most popular technique for the management of cases of corneal pathologies, which spares the corneal endothelium, including keratoconus, stromal scars, mucopolysaccharidosis, and stromal dystrophies. Among the described techniques of DALK, the most popular techniques are the Anwar's big bubble and the Melli's technique. The major limitation of the big bubble DALK are the following. It has a steep learning curve. There is a risk of intraoperative Descemet's membrane perforation ranging from 4 to 20%, which is higher in cases of advanced keratoconus and extreme corneal thinning. It is often difficult to perform this surgery in the presence of a corneal scar due to resolved eye drops. The limitations of Melli's technique include the use of a slightly complex method of air endothelial interface as a mirror to create an optimal depth of dissection, and a greater risk of intraoperative perforation due to the closed method of lamellar dissection, where the dissection is not performed under visualization. Herein we describe a new technique of DALK, that is the diamond knife-assisted deep anterior lamellar keratoplasty, or the DIA-DALK, for the management of keratoconus. This technique is safe, provides visual outcome comparable to big bubble DALK, and can be done even in cases of extreme corneal thinning or corneal scars. We developed the technique of DIA-DALK on the basis of a recent American Academy of Ophthalmology Technology Assessment report, a review of published literature that included 11 comparative studies of DALK and PK. This review found that the visual and refractive outcomes are comparable if the residual bed thickness in cases of DALK is between 25 to 65 microns. Similarly, the study published by Arjamand et al. Found that when the residual host thickness is less than 80 microns, the chances of obtaining good visual outcome increase significantly. The surgery is performed under peribulbar or general anesthesia. A circular mark 7.5 to 8 mm diameter is made on the host cornea using a disposable trephine blade whose edges had been stained by gentian violet. Intraoperative ultrasonic pachymetry is done on this corneal mark between 11 and 1 o'clock. A diamond knife set at a depth of 30 microns less than that of this intraoperative pachymetry reading is used to make an incision of 2 to 4 mm at 11 to 12 o'clock position. Medium curved fine blade scissors is then used to extend the incision on either side circumferentially all around. An open centripetal lamellar dissection is carried out using lamellar dissectors under direct visualization. The central stromal disc is then excised, leaving a very thin residual stromal bed. Cone compression is then done to flatten the cone in the residual bed by giving stab incisions. The donor corneoscleral button is placed endothelial side up on the Teflon block and is punched. The graft is oversized by 0.25 millimeters. The Descemet's membrane of the donor lenticule is stripped after staining with the trypan blue dye. The prepared donor lenticule is placed on the host bed and is sutured using 10-0 monofilament nylon sutures. "19 eyes of 19 patients of advanced keratoconus underwent DIA-DALK. All patients were intolerant to contact lenses and had best corrected visual acuity of less than 6/60. The surgeries were done uneventfully and there were no intraoperative perforations. At 6 months follow-up, the mean logMAR BCVA, average keratometry and keratometric cylinder improved significantly. The post-operative mean refractive astigmatism was 2.5 diopter and the mean post-operative spherical equivalent was minus 1.9 diopter. No post-operative complications occurred in any of the cases. The outcomes of cases with DALK were comparable to those in cases of big bubble DALK in terms of mean logMAR UCVA, BCVA, post-operative keratometry, refractive cylinder, and endothelial cell loss. Our technique of DALK is safe, predictable, and effective for the management of keratoconus and is able to offer visual and refractive outcomes comparable to those of big bubble DALK. Recently, Rama et al. Have described a technique of manual lamellar keratoplasty, wherein initial debulking of the recipient cornea is done using a Hanna's trephine. We omitted this step as we believe that there are increased chances of perforation attributed to disparate corneal thickness at the site of the proposed trephination in the keratoconic corneas. The various advantages of our technique are the following. Intraoperative pachymetry guided use of the diamond knife makes the depth of dissection more predictable and reproducible. There is no risk of intraoperative perforation of Descemet's membrane as the open method of lamellar dissection allows direct visualization of dissection plane at all times. The backup good quality tissue is not required as this can be done in advanced keratoconus with extremely thin corneas even in the presence of a scar of healed hydrops. Hence, DALK may be the holy grail in all cases of keratoconus, even with healed hydrops.